Hello, hello, hello. Hello, hello. Oh, just checking. Sorry. All right, well, it is 11 o'clock, so I'm going to go ahead and get started. Welcome to Abnormal Psychology and welcome to fall semester. Hi, hi, hi. So today, a little weird because we're on Zoom for Mondays. The plan is, barring unforeseen circumstances, is that, okay, hang on just a second. I'm getting a message from my computer. It's not happy. Okay, there are, okay. For class, normally we're going to have class on Mondays in person. in McBrien room in room 313, which is not big enough for us to be distanced. Everybody's supposed to wear masks on campus, y'all know that. So that is going to be something that is really seriously necessary. On Wednesdays, we're going to do this by Zoom. They told me straight up, we have to have class once a week in person, and that's all I am going to do, y'all. It's just, you know, this is not a good situation as far as the COVID stuff. So we're going to have class like this on Wednesday. Also, that means I get to see all y'all's lovely faces and y'all get to see my face. So there's that as well. And I just want to make sure that y'all are kind of knowledgeable as to what we're going to be doing here on that. And on Fridays, it will be online. There are already assignments in Canvas ready for you guys to do. I believe the one for this week. These are not hard assignments. These are watching TED Talks and answering a few questions on them. It should not be anything difficult. I have been teaching abnormal for quite a few years now. I found some really good stuff out there as far as videos. So hopefully those things will be interesting to you. This is a class on abnormal psych. I'm assuming at least most of you find this stuff interesting or you wouldn't be taking this class. So hopefully that will be not only relatively easy, but enjoyable and informative way for you to learn some more about abnormal psych. So for today, I'm going to try to get through the first two chapters because basically there are a lot of background stuff. I know this seems like a lot, but I'm just going to be hitting the high points here. I will go into a lot more depth on things throughout the semester on this. But the first thing, you know, you have to talk about when you're talking about abnormal psychology is what it actually means. Psychopathology is simply the pathology of the mind. It's mental illness. That's what the word actually means. And when you're talking about abnormal psych, you're talking about applying psychological science to the study of mental disorders. The dividing line between normal and abnormal is variable depending on circumstances, depending on who is the person dealing with the disorder, who the person diagnosing the disorders. There are all sorts of variables. So the dividing line is not clear cut. It has more to do with how it's impacting your ability to function. One of the things I'll say over and over in this class is you don't define someone as having a mental illness unless it's negatively impacting their ability to function on a daily or near daily basis. Now, we all have our quirks. We all have our weird. We all have our wacky. We all have our problems. We all have our struggles. Everybody gets on the struggle bus sometimes. Everybody has problems. Everybody gets sad. Everybody gets anxious. Everybody has issues. Now, that being said, not everybody has psychosis when you have basically cut yourself off from reality in some significant way. We're not talking about not being able to see that your boyfriend or your girlfriend is a jerk and cheating on you. I'm talking about having a really deep division between you and your life experience, your world experience, and reality. The psychosis kind of things are usually pretty clear cut. Those are things that you would see in people who have like schizophrenia, for example, or other kinds of really severe psychological disorders. You can have bipolar disorder so severely that you can become psychotic. You can have other, disorders that can show psychosis. Those are not common. They're not rare either. Schizophrenia is not a rare condition. It's about 1% of people. However, even with that prevalence, how bad is it affecting the person with that disorder? It varies a lot from person to person. Oh, and just by the way, I didn't even bother to introduce this part of myself. I am a licensed professional counselor. I actually work for an online counseling service, part-time, obviously, but I, have had my license for, oh gosh, near 14 years now. And I've spent 10 years working pretty much exclusively in mental health. So I've got a fair amount of experience with most of the things, not all of them, but most of the things that we talk about in this class, I have had clients who had those disorders. Again, not all of them. And I did not ever work in an inpatient setting. I only worked in outpatient settings. So I don't have that experience of working in a mental hospital, but I do have, a lot of personal experience with clients or patients, however you want to call it, who have a lot of these disorders. So I will be sharing some of those experiences with you as well throughout the semester. So I have the share screen here just to kind of keep all of us on track. When I get to the end of the list, we're done. If time does not allow for that, I'm not going to keep you later on this. That is always something that just ticked me off when I was in school. So I try very, very, very hard not to do that to you guys. So if we have to get some more, on Wednesday, we'll do that. So real important things that I'd like you to just kind of think about as far as how this class works. So mental disorders are defined in terms of the triple Ds of mental health, which is just an easy kind of way to remember what is going on. Deviant, distressful, or dysfunctional. That covers a lot of stuff. Deviant is just different from normal. And again, when you're talking about normal, there's a wide range of what could be considered normal, and there's a wide range of what could be considered abnormal. Distressful. Is it causing the person distress? Is it causing problems? Is it causing suffering? Is it causing pain? That is a really important qualifier. This is a really important thing that would qualify a disorder to be diagnosable. And dysfunctional, of course. Is it messing up your ability to function? Is it keeping you from being able to do the things that you need to do, the things that you want to do in life? Between those three things, we got a pretty good snapshot of what is going on with someone. You can have all kinds of deviance, and that's okay. There's all sorts of deviant stuff that doesn't cause people to be distressed and doesn't cause people to be dysfunctional. Now, it may not be normal to you as an observer, but to them, it's just fine. When we talk about the sex stuff, boy, there's a lot in there to unpack as far as what could be considered deviant, but isn't necessarily distressful. Dysfunctional is a pretty clear-cut thing. Is it interfering with your ability to function? Are you so anxious that you can't do your job or finish your schoolwork or have relationships that are satisfying to you? Those are things that are very obvious in a clinical setting, and most people can kind of articulate what's going on with that sort of thing. And then we also have a more kind of clinical aspect of it, is the frequency and tendency and duration of symptoms. The frequency simply is how often are you having the symptoms? Is it every day? Is it every week? Is it only when I get on an airplane? Is it only when I see a spider? That's frequency. If it's only happening occasionally, then it's probably not something that needs to be a diagnosed disorder. Now, again, there are situations. If you hallucinate occasionally and it's not because you're doing drugs, yeah, that's clinically significant. Hell yeah, that's significant. But if it's, oh, I get anxious when I have to get up in front of people, well, join the club. We meet on Tuesdays. I mean, it's like, that's the most common phobia there is. So there are things that, could be considered symptomatically a disorder, but the frequency isn't often enough to be considered a disorder. So hopefully that makes sense. Intensity, how bad is it when it happens? Do you have butterflies in your stomach when you have to get up in front of people? Or do you have pterodactyls in your stomach when you have to get up in front of people? Do you have the nervous pukes? Do you get, bad diarrhea because you have to get up and do a talk in front of your class? Yeah, that's intensity, the severity of it. How bad is it? And then the duration. How long has it been going on? Has it been going on a month? Has it been going on a week? Has it been going on as long as you can remember? So those are also all things that we use as clinicians to determine whether or not something is a diagnosable disorder. And even with that, let me just put this out there before I even get any further. Having a diagnosis doesn't really mean a hell of a lot, except it helps as far as treatment. if you're getting treatment. It's very easy to get online and look up stuff and go, oh my gosh, I have this. And y'all, when you're looking through this textbook, you will see things in your friends, yourself, your family members. You will see things. Again, it doesn't mean much. It has to do with how bad is it? How often is it happening? Is it interfering with the person's ability to function? Is it bothering them? Is it bothering other people? Is it keeping, the other people around them at bay, or is it making it really hard to get along with that person? Those are all things that have to be considered when we're talking about giving someone a diagnosis. It's not like the same as a medical diagnosis where you have a disease. It's not that straightforward in most cases, in a lot of cases. It's, we don't have CAT scans, we don't have MRIs that we can do to determine whether or not someone is depressed. We have to, look at the person and listen to them, talk about how they feel and their symptoms. So how we do that clinically and come to a diagnosis, we've got this wonderful little book, and I'll put this up here. This is my little version of it. The big one is in another room, and I think my husband absconded with it. He also teaches in the psychology department, and he's working on another book. Well, not another book. He's working on a second edition of his previous book. So he had the DSM, our household DSM. But this is what it looks like. The other one is just a big version of it. But the DSM is a diagnostic and statistical manual of the American Psychiatric Association. And basically, this is kind of the Bible of mental health, where we have all of the symptoms and the codes that you need in here to have reimbursement for your services. Say like, okay, I'll just open up this page. One that's a little more common here. Yeah, here we go. So on this page, you can see that there's bipolar 2 disorder, and there's a code that goes underneath it. That code, 296.89, is the code that we use in mental health care for billing for insurance. This is an awful lot just so we can get paid for our services. As far as having a name for a disorder, the name isn't really that important. The suffering is what's important. Alleviating that suffering is what's important. Getting someone to be able to function better is what's important. Of course, I'm coming at this from a therapist point of view, so do keep that in mind. But I do feel like that is probably, one of the more important aspects of abnormal psych is to, kind of cover some of the ways in which these disorders can be helped. So the DSM is one of the things that we use. You've probably heard of a few of these things: epidemiology, incidence, comorbidity. I think a lot of us are a lot more familiar with these terms than we were, say, 2 years ago. Hairball. A couple of years ago. But when you're talking about epidemiology, it's just talking about the frequency and distribution of an illness in a given population. So how many people are depressed in the United States, are clinically depressed? How many people are suffering from major depressive disorder in the United States in 2020? A lot. So there are those kinds of things that are just ways in which we can look at trends, look at tendencies, look at ways that the diagnostics are changing. Oh my goodness, that was loud. There's a school right across the street from my house, so it is a little bit loud sometimes. Incidence and comorbidity. Again, you're talking about the number of new cases and how many cases occur with other disorders. It's not unusual at all for someone to have more than one mental health issue at the same time. You can have someone who's struggling with both anxiety and depression. You can have someone who has, multiple things going on. So that would be comorbidity along with something else. Lifetime prevalence and gender differences. Lifetime prevalence is across the entire lifespan. What is the likelihood, or what are the percentages of people who, would be diagnosed with a certain disorder? And that, is going to be a potentially really kind of scary looking number. But you've got to think in terms of lifetime prevalence is over some 70 to 80 years. of life for your average person. So that is an awful lot of time for someone to have something at one point or another happen that would cause them to be depressed or cause them to have enough anxiety to be diagnosed with a disorder. It doesn't mean that we're currently dealing with it right now. It just means that we have at some point. Gender differences. Yeah, there are gender differences in some disorders. I don't know, the jury's still out on a lot of things as to why there are gender differences. A lot of those gender differences, I at least personally feel, and a lot of research backs this up, that there are societal influences on the experience and the willingness to share the experience of having mental health issues. So that's definitely something that contributes to whether or not people will seek treatment, how often. There are certainly less typical, kind of cisgender males that go and get help for mental health because it's considered a weak thing, unfortunately, for a lot of people, depending on what kind of socioeconomic background. There are barriers, certainly, to getting treatment and to getting help. So there are a lot of things like that out there that can influence whether or not somebody pursues treatment, whether they're male or female or somewhere in between. So there are a lot of things like that can also contribute. Who provides help for people with mental disorders? Well, you got psychiatrists, clinical psychologists, social workers, mental health counselors. All right, so let me just very quickly kind of break this down if you're not familiar with the differences. A psychiatrist is an MD, a medical doctor who specialized after medical school in psychiatry. The main thing that most psychiatrists, at least in Arkansas, do is provide medication prescriptions for people who have mental health disorders. Psychiatrists do not frequently provide regular therapy services because it is cost prohibitive, especially when you're talking about a state that's not, particularly wealthy. So when you're talking about a psychiatrist, you're typically going to be seeing a therapist that either has a PhD or a master's degree, and then you will see a psychiatrist for med checks, which would be every few months, depending on what kind of medication you're on, every few months to even just once a year, have a short appointment with the psychiatrist to just make sure your medications are doing what they're supposed to, if you are on medication, obviously. And there are quite a few disorders that do require medication for optimal functioning. Clinical psychologists are people who have PhDs or PsyDs, PsyDs, and these are people who went to college and then went to graduate school, and they have specialized in the treatment of mental health disorders. These are people who are psychotherapists. These are people who spent a tremendous amount of time after they got their bachelor's degrees in graduate school, anywhere from 4 to 7 years in some cases, in graduate school, learning how to help people with mental health disorders. Social workers are people who have master's degrees in social work, and social work therapies are a little different from people who have counseling degrees or psychology degrees, because social work is more looking at the social structure around the person, whereas mental health counselors, psychologists are generally going to be looking at the person more closely. That is not to say they're good or bad, better or worse. I have worked with really excellent social workers who were great therapists. I have worked with social workers that were not good therapists. I've also worked with counselors who were great therapists, and I've also worked with counselors who were not. So it has more to do with the individual person than training. It's just, there's a slightly different point of view not slightly, a somewhat different point of view. But the treatment protocols are generally going to be pretty parallel with social workers and mental health counselors, but they only have master's degrees. And I say only master's degrees. Mental health counselors in Arkansas and numerous other states have to have a 60-hour graduate program, and that takes about 3 years to complete. And it's still a tremendous amount of work, and we have to be licensed by a licensing entity in order to provide our services. And I had to take the same national counseling exam that a lot of clinical psychologists take. I have to keep up my license. I have to keep up with continuing education hours, lots of things like that. And just to give you an idea on the number of hours, my husband is in the psychology department as well, Travis Langley. He has a PhD in experimental psychology from Tulane University down in New Orleans. And his PhD took 72 hours and my master's degree took 60. Yeah, and you're asking, well, why the hell don't you have a doctorate? Here's why, because in counseling psychology, I would have to go and get another 60 hours. It would take me about 4 more years to do that and probably another $50,000. I'm in my 50s, y'all. I don't care. It's at this point. It would not make enough difference in my life to be worth the time and effort and money that would be required of it. So that's why. And again, I got my master's degree 15 years ago. You know, so that's the main reason. As far as the purposes of, you know, a lot of things, my husband actually taught abnormal psych in the department before I did. And, you know, he's not a licensed counselor. He's never done any therapy in his life. So I feel like I'm actually more qualified to teach this class than he was. Although he knows the disorders really, really well, but he didn't know anything about how to treat them. So, yeah, get a different point of view. One of the bigger things too is psychologists are going to be cheaper than psychiatrists to go to. Social workers and counselors are going to be cheaper still, typically, to go to. So there is the cost difference, because generally if you go to a counselor, say if I was going to have a private practice somewhere in this area, instead of charging $250 and up an hour like a psychiatrist would charge, I would probably charge somewhere in the area of $100 an hour. And don't be like, oh my God, you can make $100 an hour. Yeah, well, you got to pay for the office. You got to pay for some kind of billing service. You got to pay for other stuff. So, you know, you'd be doing good to clear, you know, 60 an hour. That, which I'm not saying that's not good money. I mean, I made good, very good money when I was working as a therapist, but it's also, you know, there's overhead involved in every job. And if you're in private practice, there's a lot more overhead than you might think. So it depends on, you know, what kind of environment and how severe your disorder is. Again, I would always recommend to the clients who, you know, I've had that I thought really needed the services of someone like a psychiatrist, I would try to refer them. I would try to make sure that they would go to a psychiatrist if I thought they needed medication to deal with their disorder, something like that. So there are those differences, of course. And then causes, moving into chapter 2. There are as many causes for people having mental illnesses as there are people. Why does someone develop a mental health issue going through an event that someone else can go through and not have any problems at all? Personal differences, personality, resiliency, just there are a million, you know, genetic predispositions. But biological contributions are definitely a significant part of a lot of people's mental health struggles. Biological contributions are anywhere from genetic predispositions to, you know, brain chemistry issues where you've got biochemical things that are going on in your brain that are heritable. You've got environmental issues as far as how you grew up. Were you in an area of high stress where you were likely to deal with a lot of stressful situations? That can affect your development, your brain development as a child. Did you go through trauma when you were a kid? That can actually affect your biology. So those are parts of the psychological and biological. And something I have heard and seen and read many, many times, the mind and the body are not separate things. If your body goes through trauma, it's going to affect your mind. If your mind goes through trauma, it's going to affect your body. These are not separate entities. They are one and the same with different facets. So if you go through, you know, a bad situation, say, if you're a kid who's growing up in Flint, Michigan right now, and you don't have safe water to drink, that could affect your biology and your psychology. So there are a lot of different ways in which contributions can be multifaceted as far as these things go. Social and cultural considerations. anything from conflict in your personal family relationships to sexual bias, racial bias, all sorts of poverty issues that definitely contribute to having mental health problems. I say it kind of lightheartedly, but it's not really. When you are rich, you're eccentric. When you're poor, you're crazy. If you have money, you have buffers between yourself and difficulty in a lot of ways that people who are poor just don't have. And when you're poverty stricken, when you are a poor person in this country, there is damn little in the way of safety nets in a lot of places. Strangely enough, this little town that we are in is actually better than a lot of big cities as far as having safety nets available, because again, we're just in a small town and we are lucky that we've got as much help available for people as we do, because I know it's not the case in most big cities. So there are those kinds of things that can be causes or at least contributors to people having abnormal psychological issues. Behaviorism, if you go back, if you can think back to when you were in your gen psych class, good old, Pavlov and his dogs and B.F. Skinner and the Skinner boxes and operant and classical conditioning. Classical conditioning is a way people develop phobias. You have a bad experience when you're a child with a dog or a cat, and you can very easily develop a phobia from having one bad experience. It's a very, very simple thing. And phobias are actually pretty easy to treat because the causes of it are usually pretty straightforward. You had a bad experience and that's why you're scared of something. That's why something freaks you out, because you had some kind of experience with it. Now, there are things that we have phobias about that are kind of, they're normal in their abnormality. We have a tendency to find creepy crawly snakes and spiders and things like that off-putting. I am not afraid of spiders, but do I want to keep one as a pet? No. I've had a tarantula on my arm before and I was like, yeah, okay, I've had enough. I've had one on my arm, I'm good. Would I want to keep one as a pet like Billie Eilish? No, I would not. I do not have a phobia. However, it's much easier for people to get a phobia for spiders and snakes and things of that, like reptiles and things of that nature, than it is for people to get phobias about, say, bunny rabbits. Don't have a whole lot of people who have fear of bunny rabbits. Have you ever seen two male rabbits fight? They're vicious. They're awful. They go for each other's scrotums. So they can be really, really bloodthirsty little critters, but they're so cute. So we don't develop phobias about things like that. So there are things, and when I'm talking about phobias, we'll go into some of these different things. When you're talking about operant conditioning, you're talking about learning through reinforcement or punishment. And there are lots and lots of ways that people can develop psychological issues through operant conditioning. You get reinforced for the wrong kind of stuff or the right kind of stuff when you're growing up. You get punished for the right or wrong kind of stuff when you're growing up, and it can affect the way you look at the world. It can affect the way that you feel about the world. You have parents who are extremely overprotective. They're going to teach you to be anxious. You're going to learn through reinforcement from them to be anxious in the way that you look at the world, and you grow up and big surprise, you have a lot of anxiety. You can have all sorts of learning involved that will contribute to abnormal behavior and psychological issues. There's also a thing that you probably have never heard of called the diathesis stress model, which is, and again, this is all in the textbook, but it's a predisposition towards developing a disorder, be it through some kind of trauma, be it through your everyday life factors risk-wise, as far as, say, you live in poverty, you have, a certain kind of socioeconomic issues or societal issues that can cause you, more problems. And of course, the biological or genetic factors that could contribute to having certain types of disorders. There are loops of causality that contribute to a lot of people's psychological disorders. You can have a tough life. You just happen to get born into a rough situation with a crappy family, which causes you to have depression, which causes you to be unable to take the initiative to do things to make your life better, which will just keep your life being tough. And it just goes on and on and on. So there are a lot of things like that that can happen. Developmental psychopathology talks about developmental norms. What is normal for an age group of people? Having a temper tantrum when you're 3 years old is normal. It's annoying. I have a 3.5-year-old grandson. He was just here last week. He had one little just snit. It wasn't a full-on temper tantrum, but I was like, oh yeah, this is why I don't like little kids. And this is my grandson, y'all. That's a perfectly normal behavior for a 3-year-old. Again, it's still annoying. It's not optimal, but it's a normal thing for a 3-year-old to get upset and just have a meltdown. It is not normal for a 12-year-old to engage in that behavior. If you look at a 12-year-old who's having a meltdown, you're going to hopefully assume that there's something else going on with that child, that maybe they're on the more severe end of the autism spectrum, that they're developmentally disabled in some way, have an intellectual disability, that something else is going on, because that is simply just not a normal thing for a 12-year-old to throw themselves down on the floor and cry and scream and wail and pull their hair and all of that kind of stuff that little kids will do. So you have to look at behavior as far as developmental norms. What's typical for a kid of that age? What's normal for adults is a little hard. Well, it's not a little, it's a lot harder to determine. People mature at different levels. People get wisdom about life at different times. Some people never acquire a whole lot of wisdom. So you can't use the developmental psychopathology on adults in the same way, but you can still have some kind of generalized ideas about what is more typical for a person, even an adult of a certain age, to be struggling with. Good old Erikson stages of psychosocial development pull in here as well. Psychophysiology is also going to be a contributor on a lot of things. You've got neurotransmitters, the endocrine system, which are the hormones that influence all sorts of things in our bodies, the sex hormones that certainly do once we hit puberty. The autonomic nervous system is the automatic functions that we have in our nervous system that keep us alive when we're asleep or unconscious or knocked out. All of those things also are part of our limbic system, which is what triggers the fight or flight response, which is what can trigger a lot of people's anxiety. A lot of people's fears are centered in that limbic system, which the autonomic nervous system has a lot to do with. So those things have, huge contributions as well. Genetics, of course, natural selection and anxiety especially are very clearly associated. If your ancestors many, many generations back were the people who ran towards danger rather than away from danger, well, you exist probably because you had ancestors that ran away from the danger. We have more anxiety in people now, which is partly because of modern life, but we're also the product of a lot of people who in the past thought it was probably smarter to go the opposite direction from the dangerous situation rather than headlong into it. Anxiety can be protective. It sucks when it's not, but anxiety can be a good thing. To have no fear can be really dangerous. So as counterintuitive it might be, as far as your mental health, it's actually protective for us to experience anxiety, at least sometimes. Now, is it protective for that anxiety to bubble up in situations that are absolutely not dangerous? There you go. That's why people have a lot of, anxiety issues in situations where it's absolutely not rational. However, we are kind of genetically hardwired, for a lot of us at least, to experience a lot of these things in situations that are not dangerous in any way. It's not very likely that you're going to get up and do a presentation in a class and threaten to fire and have a firing squad at the end of it if you don't do a good job. Probably not even going to get rotten fruit or vegetables thrown at you. What's the biggest fear that people have when you have to get up in front of other people? Oh, I'm going to make a fool out of myself. They're going to laugh at me. Is that going to kill you? No, it's not. But it's sure uncomfortable for people to think about. So you have a lot of things like that that can contribute as well. Your basic temperament, are you a high-strung, anxious person just kind of in general, or are you chill and laid back? You can see some clear differences in temperament in babies that are a few hours old. You can see babies who are clearly more outgoing, and you can see babies that are clearly more reserved in their interactions at birth, a few hours after they're born. Now, it's not absolute. Can you draw those very shy children out of some of that shyness? Yeah, you can. Can you tamp down maybe some of that gregariousness or that fearlessness in some children? Yeah, you can. You can some. But there is a certain amount of that that's just their inborn temperament. It's their personality, and it's something that you have to, deal with as a parent, and that person's going to just have to deal with as a person. We also have the temperament issue the emotional reactivity, the emotional reactivity aspect of how do you respond to bad news? Are you a person who automatically goes into emotional response, as in being all sad and crying and, oh no, it's so horrible? Or are you a person who goes into it going, okay, what can we do to fix this? Either side of that, going too far can be unhealthy. But how you react emotionally to a situation has a lot to do with how you're going to react to a lot of things in the world, how you're going to respond to your stressors, and how they're going to affect your overall functioning and mental health. Learning and cognition, we talked about a little bit when we talk about operant conditioning, but modeling is a huge part. We learn through imitation and reinforcement, of course. So the operant conditioning is a part of it, but we also learn by imitating those around us. When you're around small children in particular, if you've been around any little kids lately, they mimic the people around them. So if you have children who are around stable people, those children are going to behave probably in more stable manners. If they're around people that are really erratic and really emotionally unstable and really reactive in unhealthy ways, those kids are probably also going to react. Kids learn by observing the people around them, and they copy that behavior. So if you have parents who fight all the time and they cuss each other out all the time, that's how you get the 4-year-old who's dropping F-bombs, because that's what they're around. It is not one size fits all. It is certainly not, well, it's, you should never fight in front of your children. There are ways in which you can do all sorts of questionable behaviors in ways that are not going to traumatize your kids. There are all kinds of ways in which people can experience unpleasantness that's not going to cause them much in the way of mental health problems. Everybody's got problems. Everybody's got stuff they have to deal with. Everyone has things that come along in life that suck. How do you deal with it? How do you learn to deal with it? How did you learn to deal with it? How do your parents deal with it? How do the people around you handle life stressors? Because we all have them. Attributional style is also an issue when you're talking about causes, or more importantly, people's belief about causes of problems. Do you attribute it to your own behavior? Do you attribute it to the behavior of others? Are you ready to take responsibility for your own screw ups? Or are you going to look for someone to blame for your problems? Do you have an internal or external locus of control? Those are all things that can really have a lot to do with how well you can function in the world, especially when you talk about social relationships. If you have a really strong uh, negative attributional style where you are wanting to blame other people for all your problems, and you're a kid who goes to school with a huge chip on your shoulder, and if somebody bumps into you in the hallway, you're ready to have a throwdown and beat the hell out of them, school is probably not going to be your favorite place because you're probably going to be getting in trouble all the time. So there are a lot of things like that that can also contribute to abnormal behavior in particular. So all of these things tie into how, we look at the world and how we perceive problems that come our way, the stressors in life that inevitably are going to come our way. So you also have, again, talked a little bit already with the family background, socioeconomic factors, gender roles. All of these are things that influence the way we look at the world, the way we react to the world, and whether we react in a way that is going to be more positive or whether we react in a way that could potentially really, really mess us up is going to have all of these factors that can either make things, work pretty well for us or, cause a small problem to become a really big problem. There are a lot of things that can, help when someone is struggling, and there, of course, are things that can really hurt when someone is struggling. So I've had, a lot of different clients over the years that I have someone right now who is a very privileged person. And yet, oh my goodness, the kind of problems that this person causes for themselves is amazing to me. I've had clients who were really, really high functioning and they had no reason to be because their lives were absolute crap. The kids that I worked with, I worked for 6 years for a long-term foster home. And I dealt with kids who, to get to where I was working, things had to gone very, very badly at some point with their parents or caregivers. There were kids who had lost their parents to jail. There were kids who had lost their grandparents to death, and their grandparents were raising them. There were all sorts of really ugly things that had happened to these kids, and some of them were still so amazingly high functioning, resilient, nice kids. And some kids that I worked with who they were there because of their own, especially the older adolescents, they had made choices over and over and over again to just do the wrong thing over and over again until they ended up in this facility. So there were just a lot of different ways in which I could see so clearly. And I had kids not in that foster care setting. There's one family in particular that the kids were amazingly cool, smart, nice kids. And their family life was so bad. And their parents had gone through so much stuff. And the dad was in prison for some really heinous stuff. And the mom was honestly amazing. She was so good. She was such a good mom, but they were so poor and they had so many socioeconomic struggles. And these kids were amazing. And then I worked with other kids who were absolutely privileged little toots and they couldn't even stay out of trouble because it was just like, oh, I'm going to do what I want to do. Didn't have a thought to the consequences. So there's a lot of different things that can cause people to have abnormal behavior, but there are definitely a lot of things that can contribute, outside of themselves and around them. Sometimes it's totally someone choosing to just make the bad choice, but a lot of times it's also, people just not knowing what to do, not knowing how to deal with the problem, not being able to handle the stressors. I know there has been a huge, I got recruited to the place that I work last year um, because they're desperate for counselors because there's so many people that are struggling right now with mental health issues. Trust me, it's not like this hasn't affected me negatively too. It sucks. And I've not personally, I the numbers keep growing of people that I know that have been negatively affected or had deaths in the family because of COVID. This has been an unprecedented thing. And it's caused a lot of people a lot of distress, but it's also something that, we have to deal with. And it's not, it's not completely without precedent. We had a similar kind of thing 100 years ago, and we had some of the same problems. I was reading some things. It's very interesting psychologically. It's frustrating as a person living here with it, but it's very interesting to see how some of these patterns have stayed the same. So for Wednesday, we'll also be on Zoom. Again, next Monday, we will meet in the classroom. I can't tell you how much I'm looking forward to that. Not. I haven't been in a classroom teaching since March of last year, so that's going to be weird. So bear with me if I suddenly kind of go, yeah. So it's, but we will see you on Wednesday. Oh, and I even managed to get through that a little bit early. We'll see you on Wednesday, back on Zoom. Wednesdays will be Zoom days. I mean, part of it is just, I don't want us having to be, in the midst of each other any more than absolutely necessary. Again, I know it has been very, very hard, and I so feel for you guys. I really, really do. As far as being young in the midst of this, it sucks. I mean, I'm old. I've been married forever. This hasn't affected my life in anywhere near the way. I mean, I really do feel for you, but I also do want us to try to stay as safe as possible. Right now, in particular, we've got a nasty surge going on. So I do want to make sure that we just stay as safe as possible. So for Wednesday, we'll be back on Zoom. I'll cover chapter 3, which is basically treatment and the medications and things like that. So that takes a bit longer. Obviously, I'm not going to rush through that as much, but we'll cover that. And please take a look at Canvas if you haven't already. And we'll see you guys on Wednesday. Here.
I have a question.
Yes.
Is this I saw that this is a recorded meeting. Are you gonna upload it anywhere or?
I am going to try to figure out how to do that. Basically, I'm using, actually, this is my husband. Well, I mean, it's ours, but my husband does a lot of online. He does things for all kinds of stuff online. He was just an APA keynote speaker, for God's sakes. Yeah, he does a lot of stuff. So he has this Zoom account, but I have not recorded anything, tried to upload it. I'm going to try to have it uploaded onto Canvas, but it may take me until next week to figure out, exactly what to do. I've had a lot of stuff to figure out. And last week was so crazy because they were still at the last minute deciding what we were going to do and if we were going to meet, where we were going to meet, all that stuff. So it has been a straight up hot mess on that. It has nothing to do with Henderson. It has nothing to do with any of us as faculty. It's just trying to deal with the legislature and other things that we had to deal with as far as trying to keep you guys safe. But yeah, I'm going to try to upload these and have them available for people, just if you need them, and just for my own reference and knowledge and stuff. So that I will try to do that, but it won't be soon. It won't be until next week, probably. So, but have a good rest of y'all's day, and we'll see you on Wednesday.
All right.
Bye-bye.